1 2 1 2. Okay, we are starting now. Dear speakers, dear keynote speakers, dear speakers, dear participants, you are welcome to our roundtable. And the topic of our roundtable is the future of using point-of-care ultrasonography in ambulatory healthcare and also in primary healthcare. And which is the perspectives from the part of WONCA Europe, European Federation of Ultrasonography in Medicine and Biology, and also from VIENNA perspectives. And I want to starting this discussion with Professor Christian Janssen, who is the president of European Federation of Ultrasonography in Medicine and Biology. Because I like it very much today. I hear when he make the presentation, he speak about the democratization of point-of-care ultrasonography. And I want to ask you, Professor Christian Janssen, what we can understand in this democratization or through this democratization of ultrasonography.
Thank you for this very interesting question, and I really like to explain democratization of ultrasound. In my opinion, ultrasound is a tool, an imaging tool, which should be done by every physician and by every medical health professional who can use it to solve his problems who he has with his patients and to make diagnoses, to assist in therapy and so on. And now we have this wonderful tool of handheld ultrasound devices, which costs only 2,000, 3,000, 5,000 euros. That means they are affordable and they have a very good quality. You can't perform high-end ultrasound. This is not elastography, not contrast-enhanced ultrasound, but you can perform good quality, normal, basic ultrasound to answer a lot of clinical questions. And this allows that ultrasound is now not only a specialist tool, but can go into the hands of all people who need it at any place. You can go to the jungle and find a trauma patient and can help him with a fast diagnosis. A midwife can find a woman in an urban surrounding with difficulties with delivery, can make a basic diagnosis of the difficulties, can call the helicopter to bring the patient, the female patient, into the hospital. It can be done at any time. When the hospital department of radiology has only one young physician, you can do it at any place I have mentioned, and that means democratizations. And not only physicians can learn these techniques. We have own experience from one study with palliative care nurses who learned in 3 days to use a handheld ultrasound device to look for fluid in the pleural cavity, in the peritoneal cavity, and in a palliative care patient, he is short of breath. It is a very good tool to say he has an effusion, and you can say your palliative care physician, please bring a needle with you and make it to acousenthesis. And this is democratization of ultrasound.
Yes, thank you very much. It's a very interesting point of view. And do not forget, we have a war to our borders, European borders, and who knows what can happen. And I think it's better to be prepared for anything in each reasons. And also the pandemic, the COVID-19 pandemic, show us the importance of using the point of care ultrasonography or the handheld ultrasounds machine in the pockets of our general practitioners, because in our country, in Romania, we have very bad times and a lot of hospital was closed, and we made a lot of things, new things in our praxis, and we must to solve all the problems or the medical problems in our health system care. Thank you.
May I add a short remark? EFSUMB, for this reason, has started a webinar or a series of webinars to use handheld ultrasound in war trauma for the Ukrainian colleagues, which are part of EFSUMB and working under very difficult and dangerous conditions in their home country, and we want to support them, and this can also be related to other situations in Israel and so on.
Yes, you have right, and we must announce we have some bursary, students bursary here in our conference from Ukraine. We have 4 participants from Ukraine, and I am very glad we can support them participation here. And the second keynote speakers, please. I heard your nice presentation, and what remind in my mind the political in the to use point of care ultrasonography in the primary health care. What is your position, Professor Shlomo Winker, and what you think we can do together, the 4 organizations, the WONCA Europe, the European Federation, the World Federation, and the VECUS, to improve and to support uses of ultrasonography in the family physician primary health care also.
I will start with a very short story. When I was a student, 4th year, many years ago, we had the head of the department of cardiology, a very famous professor, and he tried to explain us to make auscultation of the heart, the 3rd voice, the 4th voice, and I'm sure that during all my years as a student, it was very, let's say, imagination. Most of the sounds that I heard was from my imagination. And you cannot see today a cardiologist make a diagnosis of aortic stenosis or mitral stenosis using his stethoscope and saying, no, it's like a seagull murmur, or is it the 4th heart sound? So, and on the other side, you cannot see any ultrasonography that said, okay, the cardiologist cannot use the echo. It's our territory. So I think the same should be with family medicine. We are not a threat. We have to work together. And I said it several times today that it should be clear that we are not replacing the specialist. We are doing totally other things, and we can work together. So the motto is how to do things together and not how to do things one against the other.
Yes, thank you. And I'm glad because we are here a lot of specialties. And I want to ask Professor Paul Sidhu, who is a radiologist, what is the point of view of the radiologist about the use the ultrasonography in the family physician's daily practice?
Thank you, and I will answer that after I answer that I too could never hear the heart sounds. So this is a confession from everyone. From my point of view as a radiologist, if I can tell a very quick story. In the 1970s, when ultrasound was first being introduced into imaging, the radiology departments didn't want ultrasound. Nobody would take it. So the only department that took it then was the nuclear medicine department at the Royal Marsden Hospital. And the person who took it there was David Cosgrove, who I think you all remember as one of the pioneers of ultrasound. So radiology has a long history with ultrasound and a love-hate relationship with ultrasound. But the point is that nobody owns ultrasound. This is the bottom line. There is no legislation like there is with CT and radiation that you have a certain amount of legal responsibility. Ultrasound doesn't have that. MRI is prohibitively expensive, so it's not something that will be everywhere. But the beauty of ultrasound is how safe it is for everybody concerned, including the patient. And the use of ultrasound should not restrict the patient's well-being. So if you can do an ultrasound to expedite the management, care, and treatment of the patient at the bedside, it should be done. Of course, there should be highly specialized areas of ultrasound practice. Not everyone doing point of care will have the ability or the desire to practice ultrasound to very high levels. So you should always retain a central sort of facility within a hospital environment where the practice of very high standards of ultrasound should continue. But it's not owned by anyone.
Thank you very much. And if you want to have another proposal for our question, please do it. And I want to continue because we are in Austria, Österreich, with our friend Peter Sigmund. He is my friend, and we starting, I think, 5 years ago to make a lot of workshops in Bratislava, in Vienna, and so on. And thank you for your participation. And I am very glad because I'm involved in practical things, and also I try to make research. And Peter is involved more in practical questions and things. And what is your point of view to use the family practitioners in all the world, not just in Europe, in daily practice the ultrasound machine, because you know the ultrasound machine are cheaper now, and it's not a problem to have a pocket ultrasound machine and to try to make the diagnosis and put the diagnosis, the positive diagnosis, and also to make the differential diagnosis. Please, Peter.
The main topic to achieve this competence is to get a wide range of education. So every national organization has to organize education standard, and to get the colleagues into the state of certification. So it's necessary not only to make a course and to get a form, but you need the certification of your national organization or of a European organization. So we can prove that we can do it on a certain standard. For these colleagues who are already working, who are already in the Middle Ages, to speak, it must be possible to achieve the competence. It must be manageable beside the work. The curricula should be viable, manageable beside the work. I've shown some proposal how many amount of diagnostic documents can be useful, and the young colleagues, they should start sonographing in the university, in the residential time. So the young generation has to be grown up with sonography anyway, as a part of physical examination at all.
Thank you very much. Let's think about the classical examination, the classical clinical examination. As a family practitioners, we had the history of the patient, we have the anamnesis, we have the signs and symptoms, but we have the clinical examination. And I think the time for the classical examination is very important, but we must to make an upgrade of this classical clinical examination, because we have a tool in our pocket, and this tool is, you can see inside the patient, you can see all the organs. And I want to ask the Professor Dominique Ami, who is a very good friend of us from France. What is your opinion, Dominique, after a life of practicing ultrasound and ultrasonography, and what you can say us about this topic?
May I make a double answer? For the French practice in private practice as a radiologist, I saw a new generation of radiologists who are overbooked for MRI, CT scan, and so for them the ultrasound is the secondary technique. But it's a jackpot because you have a huge demand for MSK or everything theory testing, and so people need a lot of ultrasound, and they are not able to do that. So of course, other people, nurses, are going to do primary care ultrasound, and I am sure that we have a role to develop that and to control. The second one is, in my experience in Africa, West Africa, we should have a tsunami. Can you believe that? In Algeria, Morocco, Mali, all these countries, all the physicians had a small echography machine unit. Secondary hand, not very good. They have not a good training, but all of them, they want and they practice echography. More or less good. And now Chinese arrive. With, if you see the Sonostar company, they have a small hand machine with linear and convex with Doppler, and in China 1,500 euros, and in the last past month they sell 10,000 units only in China, and they are waiting to open the market. And the Africa, it's a huge market for them. You know, the future of the continent is fantastic. And if we want to act and to have some responsibility, we try to help them, to teach them, to guide them, to try to help them to make a good job. If not, Chinese, Russian people are going to eject us, and they make, I don't know how they work. So a double answer.
Yes, thank you very much. I remember, I think 8 years ago, was I had a discussion with Professor Michael Kidd from Wonka Europe, and he said, for Wonka World, I think, and he said me, I am also Michael, Mihai in Romanian, and Michael, the time is coming, and I asked him, what time, Michael? And he said, the patient come to me with the ultrasound machine and ask me if it's correctly, he put the probe on himself, and he say he saw a stone, a gallbladder stone, and ask if it's possible or not to coming these times. And I want to ask Professor Sporia, because we are a clinical ultrasonographist, and also I speak with Professor Sporia about the clinical ultrasonography, not the ultrasonography made by radiologists, because it's differentiation between these things, because we had the history of the patient, we have all the data, the database of the patient. Please, Professor Sporia.
First of all, I enjoy about the term of democratization. I believe it's yours term, and I spoke yesterday with a Greek colleague. Then democratia come from there. Okay, then it's for everyone. And the logo of VIENNA for federation is ultrasound for all. And I believe this is very important to keep in mind. That is for all. Okay, this is first. Second, I like more to use clinical ultrasound than point of care. You know, Lucas Greiner, many of you know the name of Lucas Greiner, have this idea more than 20 years ago, and maybe it's better to use this clinical because we have behind Koppel in 2013 wrote a paper in very famous English review and about this point of care ultrasound in New England. Then from this moment come PoC-US, but maybe it's better to have clinical ultrasound. And I believe it's not good to divide ultrasound for GP, but ultrasound for everyone, because we have in the world of gastroenterology this fight to introduce the gastroenterologists. We fight for 20 years about this. We have courses for gastroenterologists. Still, there are maybe 2/3 of the country where the gastroenterologists are not accepted to perform ultrasound. Then we must have a common fight for everyone. Don't say which level, because don't matter the level, but everyone. And this is ultrasound for all is the best idea for everyone. Then maybe to the nurse, maybe to midwife, to give this. These are discussion, a long discussion from my point of view. But for doctor, it's any doubt that we must give for everyone.
Yes. Thank you very much.
No. If they like, because they like to go internet to treat themselves. If they like to buy a machine, a small machine, a Chinese one, they can teach on themselves. Okay, is there a problem about it?
Yes. We are starting in Romania, I think 20 years ago, with the ultrasound working group. And we have a hard working there, and I was involved in this because I was the coordinator. And finally, 5 years ago, we introduced in the curriculum of the family physician, of the program of residency in specialty of the family physician, 4 years, a module of the ultrasonography and imagistic for practice, for daily practice. Yes, point of care.
This is valid for gastroenterology in curricula, for internal medicine, for nephrology, for urology.
Yes.
Then they are lucky generation.
Yes.
Maybe the generation more than 30 are not so lucky, and we must be focused maybe on this generation because they don't have an opportunity to be trained during the fellowship.
But it's very important because this curriculum allowed us to try and to put the hand of the ultrasound machine, because if you don't have in the curricula, you couldn't put the hand of the ultrasound machine. And I think it's the first step. It's like policy statements, and we try to do that with Professor Shlomo Winker, because if you put in the curriculum these things of the uses of ultrasonography in the family physician, and not only, because this conference is entitled the ambulatory health care, not in family physician and not in primary care. But I think it's most important in primary care because we can use the clinical ultrasound or point of care ultrasonography, because you are starting to the symptoms and then you go to put the probe to the patient to see what is happened with your patient. But we can do a lot of screening programs. And I think the screening programs are very important for the first level of healthcare systems. And because I speak about education, I want to ask Mateusz, who is involved in EUROSON Poland, what is your opinion, Mateusz? Because we are friends from 10 years ago. We make a lot of workshops together. And please, what is your opinion to improve the educational the education in the ultrasound, in the clinical ultrasound?
Thank you very much for Mikhail for the question. Well, the thing is that I just want to say that I agree with Professor Sporia because I start to answer your question because I have the feeling that diverticulitis look exactly the same on the screen of the sonographic machine in family medicine, gastroenterologist, endocrinologist. Yeah, it's just a patient with pain in lower quadrant of the abdomen, and we somehow saying that it's for family doctors, but it's not only for family doctors. What we mean by the family doctors, we mean the doctors who are facing certain kind of problems, but those problems are the same in whole Europe, in whole universe. Yeah, so it's not so complicated to diagnose diverticulitis. Yeah, we need to somehow, maybe we can blame ourselves that, for example, students are not educated in diagnosis such a popular condition like inflammation of gallbladders, for example. Yeah, but it's another topic. I agree with Professor Jan Spora. The question about the education is there are two main things. One main thing is, according to EFSUMB, VIENNA, and WONCA, for example, to prepare the legal papers, what is allowed and what is the limitation of the examination. Because this is very important, but even if we love the sonography with our whole hearts, we know that it has some limitation. The simplest example of the limitation of sonography, for example, let's say it's pulmonary embolism, when you have normal image of the lungs, and everyone who's doing the sonography has a patient with dyspnea, you have the proper lung image, you need to think, okay, the image is okay, but he, the patient, is sick, and I know where to find the options, other differential diagnosis, if I have a proper image. So one thing is for WONCA EFSUMB to make the statement which are evidence-based statements, what can be achieved and what should not be achieved. Yeah, that's one thing. And the second thing is to prepare some kind of educational offer, I would say, for, let's say, physicians, generally, European physicians, primary physician, gastroenterologist. Okay, I am primary physician from one of the European country. I'm not good at sonography yet, but I really want to try. What can you offer me? Yeah, so let's try from, for example, theoretical background. We can do it online. Then let's meet in one of the European school just for the practice. Nowadays we don't need to have, for example, just practice training. Yeah, when we are meeting, we can do it online. Then we'll have the practice. Take a basic level. Take another more advanced level. So that if there is a young doctor in Europe, if he's even a student or a specialist, and he's not keen on, or for example, a sonographic enthusiast yet, but he would like to, we need to somehow prepare the offer for the person, for those people who will be in a coordinated way educated, and we will tell them not to do. We will not tell them do the sonography. Yeah, why not? Oh, it's fantastic. No, we will encourage them. Where are the points that it really helps, and where are the points it will not help you at all? And the thing is to encourage those people. It's kind of a communication. I really like your lecture yesterday, because you were talking about a very interesting topic, which is hyperthyroidism, which has different sonographic image, like Graves-Basedov, hashitoxicosis, like subacute, and they required sometimes different management. Yeah, and the sonographic examination can be the way to choose to help us the right management. And I think to encourage those people to educate in sonography, we should talk much more showing them by cases, by lectures, by meetings, or maybe using social media. How can it improve their work, their management?
Yes. Thank you, Mateus. It's very important, all you said. But we have a problem. We need training. We need trainees. We need a trainer in the ultrasonography. And it's not very easy because, as you can see, we are a few family physicians here. And we have the support of academical universities. And I want to ask Professor Dana Stoyan, who is her opinion about the support of the university for the develop the uses of ultrasonography in the ambulatory healthcare in general, but especially in the primary healthcare.
So thank you, Mihai. First, to somehow to complete your statement, so I'm a part of EduSon Romania, and education is very important. It's an online project, and you can be there, have like an abonnement, and it's on who wants to look into the case of the month or special topics. You can just make there and online and view, and it's not only in real time presentations, but also on demand presentations, and the number of presentations already listed. Mihai was also leading some.
I make the program
yes,
from the family
general
physician, family son is
so it's important because actually education is there for those who want education. So it first that it has to be let's say a mandatory level in order to be able to perform it, to put a hand on the transducer, to not to get to do more harm on your patient by the wrong information. And then it's an on demand because we all are on the learning curve in one of the positions, but still all of us are always on the learning curve as long as we work. And about university, well, universities are open for education. As you know, our university has program even for residents, education in general, ultrasound. There are postgraduate courses, and at the end there are some professors and some doctors, like everybody here, who are willing to take time on from their own small spare time just to educate, because at the end we are all here because somehow we also like to do this besides our medical activities.
Yes, yes.
It's about education of the students. Some universities in Europe, and there are not too many, start with this training, and I believe it's very important. Some of them use for understanding physiology or anatomy. Others make in preclinical or in clinical years. We started in Timișoara maybe 6-7 years ago, but was a top, and then we go down because it was mandatory. Now it's facultative one. I believe to all the level we can start this training of doctor very early during the student period, and they like to have the probe. Now the machine are cheap, it's not very expensive. University bought some machine, and a lot of people, and I believe in Heidelberg they have 20 machines for students or something. It's important to have many to let everyone to work a lot with this, and this is the direction, I believe.
I'm totally agree with you, and I want to ask Dr. Gergely Agoston, what is he is involved in education in the, I think, in the Cathedral of Family Medicine in Szeged, Hungary, and he is a cardiologist, and he participated last year and this year together with us to improve and to develop the uses of rapid cardiac assessment by non-cardiologists.
Yes.
What is your opinion, please? please.
Thank you very much. This is a difficult question because you know that, for example, the cardiac ultrasound is in the Europe is absolutely in the area of the cardiologist, and the cardiologists do not accept that I want to implement the cardiac ultrasound in the general practice or in the internal medicine. So even because the cardiac ultrasound is a very useful diagnostic tool, because if you put the transducer on the chest wall, you immediately look at for the ventricle, for the valves. But in this reason, we have to do a strict guideline or strict protocol what we have to do in the general practice regarding the cardiac ultrasound. You mentioned it's a very good idea, because for this reason the cardiologist will not accept things to do.
Yes, a friend of mine said, "This place for all in this world," and I think it's a win-win project, because the specialist can do and can see and can have the patient with pathology, not a healthy person, and don't take time with non-important things. And a family physician can do the screening programs to put the early diagnosis for the patient, because I have the second specialty, I'm pediatrician. And I saw to my practice a lot of patients who, let's see, in the teenage, who had the atrial defectum or ventricular defectum, and nobody saw this patient in 20 years. And I think it's not normal, these things. And every patient and every, from the newborns to the elderly, had a family physician. And he goes to family physician, and I want to, because Professor Shlomo said, we have some programs, some projects about artificial intelligence to help the family physician to put the diagnosis. And yesterday we saw the company from Israel who are working to the project, and just with the probe, put the probe in the 4-chamber apical 4-chamber view, or in the long axis parasternal, and you can have the diagnosis in, I think, in 2 minutes or
Yeah.
yes. And if you have a problem, you can refer the patient to the cardiologist, not stay with the patient till 20 years when the patient had pulmonary hypertension, and what you can do with this patient. Okay, Professor?
Yes, I said also in my final lecture today that at the end, generalists or clinicians are doing a lot of things, and you cannot be specialized in everything. So if we will have such aids, and you know, those artificial intelligence equipment or technology is from the remote. They are all the time renewing themselves, make themselves more easier to use. They learn from the experience of us. They are gathering information. And I think that, you know, the clinician with the machine and with the software together will give better treatment to our patients.
I would like to make a comment on this. I really love assistance by artificial intelligence. And as you said, it brings the level of expertise to so many people who have not the many cases seen in their life. But I think ultrasound is a clinical imaging tool. That means we have to have the control, not artificial intelligence. It should only be a help. Because ultrasound is not only producing images, it is a dialogical examination. It allows us to see an image, to ask the patient, and not each finding is a disease. And there's a risk of ultrasound if we make it a thing of artificial intelligence. We have overdiagnosis. And the second risk, I'm very happy with democratization of ultrasound. But in nations, democracy works only if the people are informed. And you need the informed physician. There's a risk if there's an epidemic, was told for Africa, for China, if there's an epidemic of ultrasound machines coming in the hand of untrained. And I would add, democratization of ultrasound is not ultrasound for everyone, but for everyone who is trained and who is able to make an indication. And this is a clinical task.
Yes, thank you. It's very important thing because, as I said from the first my presentation yesterday, we need guidelines, we need training programs, but to have this, we need the curriculum, and we need, I think so, in our specialty to implement this curriculum. And I think, as Matteo said, we need policy statements. And Professor Shlomo Winker said yesterday, I think, we need a position paper. This position paper is like an support for many countries, because I speak with a lot of colleagues in different countries, and I want if somebody from Greece and somebody from Kosovo want to speak about what is their problems in their countries. They can put the hand on the machine probes of the ultrasound machines. Please, someone from your countries who are participants, please. Okay. Please present.
My name is Dimitris Kounalakis. Thank you for this. In Greece, we are in a different situation than here. We have a legislation and the law allow for the doctors of nearly most medical specialties to do ultrasound, to perform ultrasound and to have an ultrasound machine in their practice only if they underpass an education of 6 months in 2 educational centers in Greece. That means about 4 persons per year for all the specialties. There are medical specialties that they have in their curriculum the ultrasound, like the gynecologist, for example. This kind of medical specialties do not need that. But for general practitioners, for pediatricians, for internists that they work in the ambulatory care, they more or less get money penalties if they had an ultrasound in their practice when they don't underpass this certification. There is no.
It's a monopoly.
Yes, it's a monopoly. I remember some years ago that even if you want to go to undergo a specialization in ultrasound, you have to request from Greece, from the Society of Radiologists, the permission to be educated outside Greece. So
okay.
That's a bit not good even for the health of our patients.
You put 2 problems. The first problem is protectionism for the radiologists to not have the clinical ultrasonographers behind them. Yes.
Correct.
And the second problem is how long will be the training program for the point of care ultrasonography, because I have in Romania also a training program in a university, academic university, yes. but it's a training program for 6 months, and you must have a lot of problems because the family physician must be in their practice every day. They don't have time to go out from the practice, and you must stay there 6 months, or I think we have 2 modules, Professor Sporia. Yes, it's a problem. But Professor Sporia proposed us something in, I think, in 10 years ago, to have the levels, level 1, level 2, level 3. And I think the level 1 is the point of care ultrasonography, the clinical ultrasound in the handheld sonography for ambulatory healthcare. And I working here in Vienna, in Austria, and also in Romania to this curriculum. And in curriculum in Vienna, by example, I think was a program to train in point of care ultrasonography for the family or the ambulatory healthcare in, let's say, in 1 week, maximal, in 2 modules of 2 days. To try to starting, and a number of ultrasonography with an expert, 100 and so on. This is a question for every one of you. How long must be a trainee for the family physician and for the ambulatory specialist, ambulatory healthcare specialist, and who can help our colleagues from Greek, our colleagues from Kosovo, and another from another colleagues from Italy, who come to me and say, Mihai, you must help us because we have a problem. We don't have how to make this training in the family physician in Italy, by example. And we have together with us in this conference and Professor Vito Cantisani. He is the president of SIAM, Society of Italian of Ultrasonography in Italy. And this is a very important question. How long to be the training program for the first level, for the clinical ultrasound? Because we have in our curricula now this in some countries, in Romania by example, but I think also in Spain, I have some friends and colleagues from Spain, and they try to make something in this.
One problem that come about level of performance is a wonderful. 20 years ago in EFSUMB we prepared this level of performance, basic level, then advanced and expert, but nobody used this one. I was the president of Romanian Society. I introduced in Romania, but everybody was against this level of performance because everyone believed they are the best. Okay, this level of performance are very, very good, and maybe it's the time that EFSUMB push a little to national society to have this level of performance. It's good because level matter when you to be trained for such for every level.
Time to be prepared is very important because I said before in the Austria they need 2 programs, or let's see, this is one program for 60 credits and another program, and you must have an expert to go there and to make, let's say, 100 examination to starting this point of care ultrasonography, or to starting in your practice, because it's just a tool. It's just a tool to see in your patient your information, your clinical information. Matteo said, but the most important thing is not, I think, the ultrasound machine. The most important thing is your brain. To use
Not only of sonography, but of all clinical imaging tools.
Other colleagues
From Greece. We all realize here that the sonography is the new stethoscope. But we in Greece, we don't have that knowledge, and we don't have the access to this. The only way I'm thinking that it's possible to be in whole Europe, Wonka, to propose that is mandatory for all educational centers in Europe that must students have the residency have 1 month or 1 week of PoCUS. This is the only way to speak the same language in all countries. Otherwise, we like that Bible tower, and we speak different languages. My opinion is that
Understand each other.
yes, to understand each other. Because okay, in Greece we have a problem with the radiologist, with one or with another. In Croatia, maybe the same or some kind the same. So if the official educational part Wonka is the top of our primary care specialty, propose to be mandatory 1 course of PoCUS to all the general practitioners, we don't have the problem. The problem solved. It's so easy.
I feel
we understand.
yeah. I feel a deep responsibility of the European societies to take responsibility in this thing, and we already discussed the matter. Of course, it would be very helpful if, for example, Wonka Europe, together with Euvocus, together with EFSUMB, would have a clear position that ultrasound is an imaging tool which belongs to primary health care, to family physicians, to palliative care physicians, to general practitioners. And we should prepare such a position paper. Second, we should together develop an educational program. I would not say that we are now able to say it should be 3 days, 3 weeks or so. I rather would say we should define how to certify, how to look for the skills and for the expertise, not only a matter of days or of some courses you have attended. We have to discuss this, and we will
Training rules.
Yes, we have to set a frame for this. And we already discussed with the Greek colleagues that we will take this responsibility. And I say that EFSUMB will do all we can that we make an educational effort in the direction of family physicians and GPs.
Thank you. And 1 minute for Professor Shlomo. Your opinion.
My opinion is quite clear. I think that, again, it's a matter of terminology. We don't like to have mandatory things because we are not a regulatory authority, but we are recommending. And if the highest association for family doctors in Europe is recommending, I think it's strong enough. Mandatory related to the EU, to Brussels, not to us.
Okay, thank you. I am Professor Gazman from Kosovo. I want to say that we made ultrasound in Kosovo more than 5 years, and we have more than 30 family physicians in primary care who made the ultrasound every day. But we have in our status, we have that can do that in primary care, but we need a diploma or we need a certificate, and we are same like in Greece. We need this certificate to take in Albania or in Kosovo, in one place who is one company with a radiologist and who made a training. The training is more than 5 months. But I want just to say, yes, I want just to say that really, we want to do that, but we need diploma, which is accredited from I don't know, from which place. We need that diploma. When we have that diploma, I am sure that every family physician in Europe, in world, can do that. I saw that in Botswana. I agree with Professor from France that in Botswana, every doctor have web application in the hand, and they do every day the ultrasound. I saw that in Open Medical Institute with doctors from Botswana, and he say every doctors do that. We are in Europe, and we must do that because we are before maybe 100 years with this medical equipment. And with medical informatics, every day we can do that. Thank you.
Thank you very much. And this is very important. Yes.
There are societies like the European Respiratory Society that provide modules, paid modules more or less, where a limited number of people have a theoretical education, and after that each person is spread to different centers for a small amount of days, that it could be some days in a period, in small periods, in a training program, in order to provide some kind of diploma that is more or less accepted as a European society across Greece. Could this be an alternative for an initial number of people that they want to have a certification in countries that do not have educators? For example, I was very happy to see that there are educators that can think that they are general practitioner, that they can think as a general practitioner, and that can educate other people. Because even to be educated by a radiologist is not the same thing. So probably we could think this alternative too. Thank you.
Like a program trainee for trainees. Yes. It's very important. Yes,
Yes,
Matthias?
I've got one comment. I'm just wondering, I don't know if it's a good idea, because we are talking a lot about doctors, and maybe one of the options in communication with different society about the problems which you mentioned in Greece, it's a patient's point of view, so that we would like to have the same level of access to sonographic examination all over the Europe. For example, if my mom will come to Germany, Austria and Greece, will get the breast abscess, for example, which is not very serious but required treatment, I would like her in Europe to have the same chances to get to the primary physicians who can diagnose the disease. Maybe in communication, the way of thinking from the patient's point of view will be much more difficult to postpone, or difficult to criticism of different society. Just the idea.
Yes, nobody criticizes now. We try to open the doors for the family physician to have access to the trainee programs for the point of care ultrasonography or the clinical ultrasound, as Professor Sporia said. I working, I think, 25 years ago to make this in Romania. When I start in Romania with Professor Sporia and Professor Badia from Cluj, we are starting together to train. They are in the university. I have an ultrasound working group, and we made a lot of workshops in the physical modules like this, and also we are now in the online, as you make in Poland. It's, I think, a very good idea, because when I start in Romania, just 10% of the family physician had accreditation to practice ultrasonography. Now I have the data from our database from medical college, and we have 25% of family physicians who had accreditation now. But I fight for this every day. This is, I can say, and Professor, what I think can confirm me, is not very easy, but I try to make presentation, I try to make programs, I try to make curriculum, and to demonstrate, I try to make books and I try to make articles and research to demonstrate it is a good things in the future, but somebody in every country must to open the doors and to have a very good relationship between the family physician and specialist and other specialties like radiologist. And I am glad Professor Paul Seed is radiologist, Professor Dominic Amis radiologist, and we stay together to this round table, but without table, and we try to debate. This is a very important thing, not only in Europe, but I think also in Israel, as Professor Shlomo Winker said. It's a problem of misunderstanding, because if the family physician are training in the clinical ultrasonography, the quality of the diagnosis in the primary health care will increase. I present yesterday on research how much improve the point of care or the clinical ultrasound in a very good examinator. Yes, you have right. You must make program from the training, but it's very important to put the real diagnosis to the patient. And the first, I think, winner will be the patient, because the patient will have a good diagnosis and early diagnosis in real life.
I like to say you a funny story about a radiologist and GP. This was some years ago. VIENNA, World Federation, decided to have training of all GP from Faroe Island. This was proposed by Christian Olsson. That is, no, they are 50. No, but all the doctor, but they are 50, and they was trained for 2 days by all the specialty, because those radiologists. But VIENNA was with the idea. Then a radiologist that was born in Faroe Island for this reason go there and take all the GPs in 2 days, finish a very basic level ultrasound. Then can be done in Kosovo too, because it's not very, very large. Not maybe in UK that is very, very large. But this is somebody that like to make this and to fight for this, because it's national fight. It's not a European fight. Finally, it's a national fight to fight with the authorities that are different in different countries.
Yes, thank you. And finally, I want to thank all of you, but I want to give the possibility to Professor Paul Sidu to say something, Professor Christian Janssen to say something, and Professor Shlomo Winker to try to close this debate and to starting our workshop, because the time is our enemy now.
Okay, I listened very carefully and heard all the arguments, and of course it's correct that you have to bring the ultrasound to the patient rather than the other way around. But I give you some warning as well on this. First of all, don't make it too difficult for the primary care physicians. Don't put the expectations of ultrasound at too high a level, because you will not get people interested in doing it, because everyone has a job and you can't, as you say, be specialized in everything. So you have to think very carefully about your core curriculum and very carefully about the expectations of how far you want primary care to go. There will be some primary care physicians where it will become very good at certain things and be excellent in that field, but there will be a small number and in a narrow field. So make it simple for the guys and the girls to do the ultrasound and start early. And the best place to start is already happening is in medical schools. Because if you have that basic ultrasound from your medical school, the training becomes so easy.
Okay, very short comment. I found it a very useful discussion. We shouldn't blame the radiologists for all the problems, not all the specialists, and we have to work together. I expect that in 10 years we should have the situation that every young doctor coming from the university, leaves the university, should have a basic diploma certification in ultrasound. And of course, this is certain, I want to say, if you want in Greece and Kosovo and in other places to have an effort of EFSUMB to create an educational program and a diploma, if it will help you, we will do that. Together with Wonka, of course.
One sentence. The most dangerous thing in ultrasound is the operator. Yep. Okay.
And
Totally agree.
I will have one sentence to summary. We had a round table without a table, and we had a debate without a debate, because all of us well agreed that we have to continue and to progress.
It's a large consensus, and we must to support all of our societies, VECUS, EFSUMB, VIENNA, and Wonka Europe. I think must, this too hard word, must to support, but it will be better to make a position paper to support these uses of clinical ultrasound or the point of care ultrasonography in the ambulatory healthcare and the primary healthcare. I think it's better to have this first step, and then of course to think about the training programs, the level of quality of the training, and all these things. And I think it is a good start for us. And I want to thank you, all of us, all of you, for this very nice discussion and very open discussion between all the specialties from this round table. Thank you very much.